Okay. All right, gang. So here we go. Let's do a little bit of makeup, shall we? Again, really appreciate everybody hanging in there with me this semester. This has been really very frustrating and challenging for me, and I know it's been frustrating and challenging for you guys. Such a nice conversation with Sandy, who really read me the riot act, but at the same time really kind of got me engaged to think about, all right, well, what kinds of things do we need to make sure that we cover? I hope that I do a good job here for you guys. I take it very personally if I don't, and so obviously so far I've taken this very personally. I'm sure sometimes it doesn't come across that way, that I'm very blasé about it. Part of it is, I have been held accountable for some stuff that I don't have control over outside of classroom, and so for my failings to you all, I am sincerely sorry. But I think we've got some really good information here that we can get through. So I'm breaking up some of these lectures a bit smaller, and I'm going to see what we can cover here in relatively short chunks. So going back over the information that we have for the first half of this semester, there's a couple of lectures I want to do here online that I think is going to be rubber meeting the road kind of stuff. So ear canal. Let's talk ear canal. Let's talk very clearly and specifically about ear canal. All right, I'm getting a message that says PowerPoint is trying to recover. PowerPoint is restarting. Let's see how we do here. Boy, do I love computers. All right, well, that was my attempt at getting things started. Ear canal. We're also going to do a middle ear lecture. It's going to go over a fair amount of surgical stuff as well as the medical workup stuff. And we're going to do some prelingual cochlear hearing loss. All right, let's see. Nope, not these. There. Okay. Ear canal stuff. Okay. So let's talk about ear canal infections. This is an otitis externa, just as a general broad categorization. It goes over a couple of different things. When you talk about otitis externa, just the general description of an infection being an inflammatory condition, given that this is of the skin of our ear canal, which is stratified squamous epithelium. It's just like regular skin, where you've got multiple layers. You got the layer on the very, very bottom, and you have tougher and tougher skin, keratinized skin, as you go to the top levels. Well, if you get an infection of that, then you can have some swelling, you can have severe pain, so ear pain, severe otalgia. A bacterial otitis externa can be broken up into a few different kinds, known as an acute diffuse, acute localized, chronic, or malignant. And the type of bacteria that causes this is almost always this bacteria called Pseudomonas aeruginosa. And it's that specific one that tells us which antibiotic can be used to target that. So let's just talk a little bit. The acute diffuse, this is the traditional quote-unquote swimmer's ear. It's just symptoms of this are that it's painful. There's a whitish discharge. It's just exudate, this watery stuff, but it smells. Otologists would treat it otologically by suctioning all the nasty stuff out and putting in antibiotic drops as well as a corticosteroid. The corticosteroids, it's a topical steroid. It's used to promote normal skin growth, so the healthy skin growth. An acute localized bacterial otitis externa comes in one of two types. A type 1 is basically an ingrown hair. It's called a furuncle, and the bacteria that's associated with that ingrown hair is a Staph aureus, Staphylococcus aureus, is the bacteria that causes, or that is the infection. A type 2 is a bullous meningitis. This is where you have a blister really deep in the ear canal or literally on the eardrum. That hurts. It's typically viral in nature. There's really the only thing that you do for this type of thing, for this bullous laryngitis, is keep an eye on it. You take pain medication like an over-the-counter Tylenol or Advil, and otherwise just let it run its course. Now, this acute diffuse, acute localized, this is separate from your chronic bacterial. This is something where you have a diffuse, red scaly, it's like eczema type of skin rash. It's a dermatitis. It's more itching than it is painful. It can cause enough swelling that the ear canal literally is almost closed, or could close all the way. You can have these acute exacerbations where things start off, or that's kind of this low level of itchiness that's there. You get some where it just gets bad and it starts to drain, and you scratch at it and it drains some more. Some of the best ways to take care of this is literally to do vinegar drops with like half white distilled white vinegar, half hydrogen peroxide. And literally it's douching the ear canal, and then after rinsing it, rinsing the ear canal with this mix, putting on a topical steroid, that corticosteroid. Sometimes you'll hear about where the ear canal has stenosed down quite a lot, where they'll take a little wick, it's literally like a candle wick, and mix it in that vinegar and peroxide and slide it into whatever tiny little hole there is that is the ear canal, and then literally like just drops of vinegar and peroxide onto that wick, and it wicks up into the ear, and it can slowly start to open that ear up, and putting a topical steroid on the outside that can open the ear up again. Alright, now there's the bacterial otitis externa, and then on the other side there's fungal otitis externa. Now there's a balance between the amount of fungus that's on the skin and the bacteria that's on the skin, and those two are actually in a constant battle with one another, essentially for real estate. And because you have both at a normal level, basically both are kept in check. Where one kind of overpowers the other is where you can get an imbalance. And particularly if this imbalance is where you have, for instance, over-treated a bacterial otitis externa, then you can end up with a fungal otitis externa. A fungal type, this is, it's a fungus. The type of fungus that does this is this stuff called Aspergillus fumigatus, Aspergillus niger, or Candida albicans. The Candida albicans, that's a yeast infection. It's generally characterized as there being some budding, like literally looks like, well, the spores, you can literally see them with a little magnification. It's different color down the canal. There's a lot of debris, there's itching, there's pain, and of course the way to treat it is with an antifungal ointment. So let's take a look at some pictures. You guys have told me that this is, my mouse doesn't really show up too terribly well. I think that it doesn't, but I've got this triangular piece in front that's the tragus. It looks like it's pretty nasty, but this is basically looking into the aperture of the ear canal, and all these little bits, these kind of brownish green things, those are spores. That's the budding of the spores, literally seeing in here. The whole ear has just a lot of debris. This is a close-up. The two arrows are pointing at this white budding. The orange on the top left, that's earwax, kind of continues down to the left. The gray, bluish gray, kind of down in the back, that's the eardrum. And you can see more normal skin between the area where there's the white budding and there's the canal itself. Okay. Here's an example of chronic bacterial otitis. Canal is stenosing way down. It's a wet ear. This is where a wick would be put down into that, and you'd get vinegar and hydrogen peroxide mix. Here's another chronic case, bacterial otitis externa. This is where the skin itself is just raw, it's angry. Down the deepest part, that's the eardrum itself, and just it looks like it just has a bunch of nasty skin growing off of it. That's, basically, you see something like this, you're not going to be sticking really anything down in that ear canal, whether it be an earphone or a hearing aid. This is a case where someone needs really good, careful management by an otologist, specifically an otolaryngologist at least. All right, so moving on, earwax impaction. Let's think earwax impaction. The earwax is normal, earwax is healthy, you're supposed to have it. Normal function of earwax is for protection, it's for cleansing of the ear canal, and it's also for lubrication. Typically, what I've understood, at least from my reading, is that earwax impaction happens in about 10% of the population. In younger people, it happens more often, like 10% of the 8 to 17-year-olds. In adults, it's only 2 to 3%, and in the elderly, quite a bit more often. That's because their sebaceous glands get dry. In fact, it's really not producing very much oil anymore, and so the earwax gets more dry, and so the ear canal doesn't have its normal outgrowth, the normal shedding of all the squamous epithelium. You get more earwax impactions if a person uses Q-tips. That's in part because people don't know how to use Q-tips correctly, that instead of kind of going around the ear canal, they might just go in, and that of course just is like a snowplow. It's building up more earwax, and at the same time it's also stimulating the skin, and it's basically fooling the skin into thinking that something like a bug or some other foreign body is trying to get in, and so as a defense, your ceruminous glands are going to just produce more waxy substance. That's the cerumen. You're going to get more sebaceous glands producing, so you just make more wax when you do that. So ways that it's treated are with a ceruminolytic. Typically that's just mineral oil and hydrogen peroxide, like 50-50. That's just to break up the mineral oil is to lubricate and soften up the wax. The hydrogen peroxide breaks down the proteins that's in the cerumen so that it's just more liquidy. Performing ceruminectomy, we're going to talk about that in a second. One way to do it is with irrigation, literally just squirting water in there. If it's an impacted earwax, irrigation is not necessarily a good idea because you don't know what's past that. You don't know what's going on down there. So even though irrigation is used very, very often in primary care offices, to some extent it can be uncomfortable, at least, experience for people. If you do irrigation, you need that water to be roughly body temperature. Otherwise, you run the risk of a person having a caloric response, meaning you cool down one ear canal and it's significantly colder than the other ear canal, and so you make them dizzy. Probably the safest way to do it is with suction. Literally like having a vacuum and having an ear, I can't remember what they're called, just a small gauged suction, placing it down and literally grabbing hold with air, suctioning on it and just pulling that straight out. And then another way to do it is with curettage, which might be with your pen light or with an earwax curette. You do run the risk of cutting the ear canal, and so don't recommend using curettage unless it's very unless it's soft wax and you can really visualize everything. It should be in the outer half of the ear canal, further than about halfway down the ear canal, and I wouldn't recommend you using curettage to get the wax out. one thing about earwax impaction and doing cerumenectomy. According to the insurance codes, the CPT codes, the Common Procedural Terminology code for how you bill insurance, that's the actual procedure done. Cerumenectomy is listed in the surgical CPT codes, and given that audiologists are not surgeons, then it's just defined that, generally speaking, audiologists are not reimbursed for any surgical codes, and therefore we're not reimbursed by health insurance for doing cerumenectomy, which is fine. We don't need to be allowed to bill insurance. However, if a person that you're seeing does need cerumenectomy, and they do have health insurance, and say you're billing their health insurance for testing, for hearing testing, then if you're going to do cerumenectomy, you do need to charge them for it, but you also need them to acknowledge in writing that if you do the cerumenectomy and you charge them for it, you cannot bill their insurance company. And so this is something referred to as an advanced beneficiary notification, or an ABN, advanced beneficiary notification, where the person acknowledges, I could go to my primary care and they could do the cerumenectomy, and instead of me paying the bill for this, my primary care could bill my insurance company, rather than me paying out of pocket at the audiologist's office. That said, a person's at the audiologist's office, and oftentimes, as long as you're not charging too much for doing the cerumenectomy, they often will just say, "Oh yeah, no, I'll pay it." But again, for paperwork purposes, for compliance with health insurance regulation, you do need that advanced beneficiary notification. All right, one of my favorite conditions of all time, I've never seen it. I've only seen pictures. This is something called keratosis obturans. This is not earwax impaction. It is an impaction of a skin ball. Basically, it's just faulty migration of the skin. Almost always happens in people who are at advanced age, literally when it's pulled out, and this needs to be pulled out by an ear, nose, and throat physician. It is like this impacted plug of skin. It's absolutely disgusting. It looks a little bit like a finger, like literally being removed. Apparently feel better after it's out. But that would suggest that this person's going to need their ear checked on a fairly regular basis, probably about every 6 months, because if it happens once, it's always going to happen. All right, so let's talk about contraindications to an audiologist performing cerumenectomy. These are not an exhaustive list, but these are really important ones for you all to know, and to know intimately well, because I will test you on these specifically. Reasons not to do cerumenectomy is if it's a pediatric patient. Now, I'll let you guys decide, once you're licensed audiologists, what constitutes quote-unquote pediatric. I will admit that I have done cerumenectomy on hearing aid patients of mine who are under the age of 10. That said, they were, this in particular, thinking this little girl, she was absolutely perfect, holding still, had earwax taken out by another audiologist before, and it was perfectly okay. There may be some 15-year-olds that you wouldn't want to go near. So again, I'll let you guys make that call. But on children, just in general, you don't do cerumenectomy. Don't ever think about doing cerumenectomy on a toddler. It's just way too much liability for you. Given that the ear canal is highly, there's a lot of blood vessels, it's actually very easy for the ear canal to bleed. What we need to worry about here is causing an abrasion in the ear canal, and that abrasion not healing easily the way it normally would in most people. So the reason why we don't we wouldn't do earwax removal is if a person has hemophilia, some other blood clotting disorder, if they're diabetic, like as in they have diabetes that results in them having poor wound healing, people who have diabetic neuropathies, for instance, people who have sores that don't easily heal, people who need to, diabetics who need to see a podiatrist on a regular basis. Anyone who has diabetes and has lost a limb, for instance, that they've had to have an amputation, that is just flat out demonstrating they have very poor wound healing, and you don't want to remove the wax from their ears. You don't want to do cerumenectomy on someone who's had surgery on their ear canals. Of course, I also look at this and I say, aha, right, or surgery on their eardrum. So I apologize. Let's add prior surgery on ear canal or on eardrum. For instance, if someone has PE tubes, don't recommend doing cerumenectomy. If someone has a tympanoplasty, they've had their eardrum repaired, I don't recommend doing it. And certainly if they've had surgery on the canal itself, that would suggest that the blood supply is not really normal, and it could be a problem. Some states, our state licensure forbids doing the audiologist doing cerumenectomy. Now, in Massachusetts, it is considered part of our scope of practice, and so we can do it. We can't bill insurance for it, but we can do cerumenectomy as long as your scope of practice in your state allows for cerumenectomy. Your malpractice insurance does follow and covers you for work performed according to your scope of practice. So Massachusetts, our malpractice insurance does cover for cerumenectomy because it's part of our scope of practice. If you don't know, if you can't figure it out going on state licensure websites, you contact your state board of licensure for audiology and you ask them specifically, and they need to give you an answer. Other reasons why you wouldn't do cerumenectomy on someone is if they have an immune compromise. For instance, if they've had an organ transplant, they have to take immune suppressive therapies. If a person is taking any medications that would cause an immune compromise, and there's quite a few of them. One of them in particular is chemotherapy that causes immune compromise. And certainly if a person is HIV positive, you don't want to do cerumenectomy because they may not be able to fight off an infection, and that infection can cause something rather significant in their ear canal. Certainly not a place that you want to have an infection, as we were just going over with acute, diffuse, chronic diffuse bacterial otitis and your otomycosis, your fungal otitis. If a person is on blood thinners, for instance, if they've had a stroke or if they have a heart condition, they need to be on blood thinners. Most common one would be Coumadin. The brand name is warfarin. If their ear canal bleeds, it might just bleed and continue to bleed. So don't recommend them being on. If someone's on blood thinners, I recommend them not doing cerumenectomy. And if a person has cognitive disability, certainly do not recommend doing it for the same reason that you wouldn't on a lot of pediatric patients. You wouldn't want to do this given potential for there to be a problem. So remember this list, know this list, and remember that it's not just surgery on the ear canals. It would be, for instance, eardrum surgery. Okay. So what kinds of things can happen in ear canals? Weird stuff of ear canals. There's stuff called exostoses. This is actually really common. You have these bony growths in the bony region of the ear canal, the osseous portion of the canal, so that's deeper inside. Typically it's on both sides, and it's associated with repeated exposure to cold water, particularly when a person is a child. So it's actually very common around here that you may look down inside a person's ear canal and you see these big bony growths where it's not a normal looking ear canal because they spent their summers as a kid swimming in Cape Cod, and it's cold salt water, and water down there supposedly, no reason otherwise to think so, this is just generally what I've always understood, that cold water can literally cause the bone to somewhat overgrow. Now, different from exostoses are osteomas, and an osteoma is this, it's not cancerous, it's this neoplasm, it's this weird growth of bone tissue. It's just like one ball of bone. It's typically only on one side. It's narrower at the base and gets bigger. Exostoses, it's bigger at the base and goes more to like a peak. Other things that can happen, particularly in older people, you've got collapsing ear canal. This also happens in young people. Their ear canal can look relatively open until you flatten the pinna. For instance, using a TDH earphone, flattening a pinna against their ear and it causing that outer 1/3, particularly at the first bend, causing the collapse of the canal there. Other things that can happen is that you can have a congenital narrowing of the ear canal or literally just an absence of the ear canal. So let's look at a couple of these. So here's a picture of exostoses. These great big two basically peaks of exostoses are what you might call kissing. That very possibly is going to need eventually some kind of surgical intervention, because getting earwax impacted behind there is pretty common and certainly can happen quite a bit. Here's foreign body down in the ear canal. These are really overgrown exostoses with sand, obviously from swimming in salt water down at the beach. Oh, by the way, exostoses is referred to as surfer's ear. It makes a lot of sense. Surfer's ear. Not swimmer's ear. Surfer's ear. So here's example of keratoma, where this is actually soft tissue. It's thickened epitheliums, these little nodules. It looks a little bit like skin tags, only they're not like literally coming up and out. Alright, I had talked about normal skin migration, normal growth. You see these rings? These are rings of desquamated epithelium. It's skin literally growing off from the center of the eardrum, going out and out and out, almost like rings of a tree. And it literally grows outward, almost in a spiral pattern in normal ear canal growth. You can see this is down in the bony portion of the ear canal. There's no ceruminous glands, there's no sebaceous glands, so you just can't see any pores, even under magnification. And you don't see hairs. Well, out here, this is the edge. You see a little bit of hairs here, these dark lines on that left-hand picture. That's kind of showing there's a little bit of wax, kind of brownish-orange wax that's at the very bottom of the image. That's just showing basically where that soft tissue, outer, say, 1/2 to outer 1/3 of the ear canal, joins up with the bony portion of the ear canal. Normal, healthy ear canal, literally you see the ring where all these bits of skin that are growing out in this ring-like pattern will hit the line where ceruminous and sebaceous glands start, and you get a line of earwax right there. And as it's growing out, that's all normal and healthy. So here's an example of wax that's basically really big, like sloughing off of like sheets of skin, what you might refer to as desquamation. It's roughly about 50% blockage of the ear canal, moderate amount of cerumen. Looking at it, it looks a little bit dry, but it's a little bit moist. It's not overly, but that looks fairly deep. It's hard to tell because we're just looking down, say, an otoscope, even at best, like a video otoscope. Really hard to judge distance with this, so I can't tell how far past this earwax is the eardrum. So that would be unsafe to take a curette and place that curette down past the cerumen and try to pull it outward, because you could just bang right into the eardrum and that would hurt. Here's occluding cerumen. So these big white lines right across it, that's hair. And that's basically your video otoscope or your regular otoscope just having the light saturate on this and just kind of like flashing back. It's probably somewhat dry, although there's parts here where it's shiny that looks like it might have some looseness to it. This kind of earwax, you really would need to just dose that in hydrogen peroxide and mineral oil to loosen it up a little bit. Safest thing to do when taking out earwax like this, 3, 4, 5 days of a cerumen-olytic. If you get just a little bit of a hole somewhere through that where you can actually see the eardrum, you would want to do a tympanogram. Confirm that you have normal ear canal volume as opposed to very large ear canal volume. If you've got a very large ear canal volume, that suggests that your eardrum is not intact, and so you don't want to be putting any more drops of any liquid down into the ear canal. You don't want water or any of the skin debris especially to get down into that middle ear space. It would cause an ear infection and could cause worse. So once you're able to do a tympanogram, if you can confirm that it's a normal volume ear canal, then you can either flush it out with water. If you have suction, then you can suction it out. You could use curettage, although with this, again, it's very hard to use curettage and get out an occluded bit of earwax. So often with this, if it really needs to come out quickly, that's often when I would refer to an otologist. So here's wax. This is actually more common in persons of Asian descent, that you'll see this dry, yellow, flaky wax. Just difference in the actual skin, difference in the ceruminous and sebaceous glands. It can be a bit harder to do cerumenectomy when you have this dry wax like this. Oftentimes the wax doesn't come out on its own. Not easily, not with curettage. So sometimes this takes a bit more TLC. Some foreign bodies. Someone put a cotton swab, a Q-tip, down their ear canal, rummaging around, and then pulled out, and the cotton swab left behind. You'll see that. That's not very comfortable, and earwax will build up around that. Here's something that you have earwax for, is to keep little guys like this from going down and banging against your eardrum, which would be loud and tickly and painful and just not a whole lot of fun. So there's good reason why we have earwax in our ears, and we don't want our ears to be squeaky clean, because that's the purpose of earwax, is to trap guys like this, basically like little tar, just keeping them out. That's not a cool sign. You don't want to see that down someone's ear canal. Okay, so let's shift over into thinking about your congenital external ear problems called dysplasias, auricular dysplasias. So we've got a little bit of vocabulary. Aplasia, that's where you have a lack of development of the temporal bone and the posterior location of the TMJ, the temporomandibular joint, where you can actually, if you put your fingers in front of your tragus and open and close, you can feel that joint. You can feel where that opens and closes. Well, when you have this lack of development there, you may just have absolutely no ear canal. In fact, half of patients with something called Treacher-Collins syndrome, they have just no ear canal, and in fact, because of what's going on with their TMJ and their ear canal itself, they're not really candidates for having an operation to open their ear canal. You will actually fairly often, it's not uncommon at all, see something called a preauricular pit, also referred to as a preauricular sinus. It's basically just like a little skin pit where you can get some nasty stuff in there if it's infected. It's something that either a dermatologist or an otolaryngologist ought to take care of. That's just a difference. It's not that atypical. Preauricular cysts or fistulas. This is in embryologic development. Some of the there's branchial arches and clefts. That's basically what ends up making up our ears as we're in utero, are these branchial arches and branchial clefts. Well, if one of the clefts fails to close, you can have basically what is a big fistula in front. It's not as small as a pit. It's just big. It's a big pit. Preauricular tags. skin tags happen, and it's really actually very common to have a preauricular tag, particularly from one of these branchial arches failing to just fully migrate into the position that's supposed to be in. These tags can either be cartilage or they can be skin. Typically, they're just excised by plastic surgery or perhaps by the otolaryngologist. Hemangiomas. These are these localized vascular dilations. They can be small, they can be very big. It's actually very common to have these either on the head or on the neck. You'll often see them near the ears. They're pretty common in preemies, premature children who are born and spend some time in the NICU. And then last thing that I'll mention, you can have these arteriovenous fistulas. Normally you get exchange between your artery, the oxygenated blood, and the veins, which is the deoxygenated blood. That communication happens way out into the capillaries, like the furthest reaches of your circulatory system. But if you get some abnormal communication prior to those capillaries, you can have this fistula. Basically, blood is exchanging between artery and vein. When that happens around the ear, and it does happen around the ear because the ear is highly vascularized, you can see some weird stuff, particularly down the ear canal. Here's a really good close-up of a preauricular pit. As noted, that could become a cyst if there's dirt and debris and nasty stuff that gets in there and becomes infected. Just a skin tag on the earlobe. Oftentimes we'll see skin tags on the in front of the tragus. Here's a rather nasty looking infected preauricular cyst. So if we go back a little bit and we see this guy, imagine that's down a little bit toward the tragus and it gets inflamed, infected. That's what this could look like. It's nasty. So let's think a little bit about embryologic development. I already mentioned these arches and clefts. So where outer ear is concerned, our embryologic in embryologic development from gestational week 4 through gestational week 28. That's the time when the external ear is formed and the ear canal is formed. 4 weeks into gestation, you've got these, I call them branchial arches, pharyngeal arches. It's basically down along the neck. You've got these branchial clefts, pharyngeal arches, and there's 6 that, as they start off on the neck, they migrate up toward the side of the head. Eventually, they form the pinna. At least the first 2 pharyngeal arches. At week 7 to 8, the cartilage develops. The pinna continues to grow. That continues to grow until about age 9. I've suggested it continues to grow until you're about 12 years old, because 12-year-old boys typically have really big ears relative to the size of their head, and that's because you have an adult-sized pinna sometime between age 9 and 12. Your pinna does continue to grow throughout your life, as does the tip of your nose, also continues to grow throughout life, but it tends to slow down considerably between the ages of about 12 and about 60. Between that time, your ear does grow and change, but during the first several years of life, your pinna and your ear canal grow rapidly. They grow about as fast as your feet do. So just something to bear in mind when you are talking about pediatric audiology and having hearing aids in a child's ear. They do need their ear molds remade on a regular basis because their ear canal is changing shape, and the ear mold ends up being too loose in the ear. Okay. 7th to 8th week. That's basically where the pinna is there. You can see the pinna. At the end of the 8th week gestation, the ear canal, or external auditory meatus, forms from the first pharyngeal groove. you actually have a solid skin plug near where the eardrum will be, so the ear canal is not open. Okay, the word patent means open. From weeks 8 to the 20th, you get migration of the external ear tissues. At the 21st week, the auricle and pinna, it's got its adult configuration. I apologize, I said it at the 7th to 8th week. It's moving up there. Yes, the cartilage is formed, but it's not up in its appropriate full complete adult position until the 21st week. The ear canal shape continues, but it continues to grow. And roughly at the 28th week, the skin plug that basically is filling the ear canal basically just dissolves. I try to reconcile that with understanding how babies are born at 24, 25, 26 weeks gestation and their ear canals are open. I'm actually not convinced that they're totally open when they're first born. It may be that it's close to, and it'll start to dissolve once they're out of, out way too early, but out. But according to textbook for embryologic development, it's not until the 28th week that the ear canal itself is actually open. So I go over this, the embryologic development, because if things happen wrong sometime along, say, between weeks 4 and weeks 28, something is wrong then with the external ear. So that's the times that it can happen. So malformations, for instance, you can have a stenosis. You can have an atresia. That means that ear canal is not open. If you have an atresia, it can be just soft tissue, or it could actually be bone, and which it is actually has a rather distinct difference in how it might be managed, both audiologically as well as surgically. So here's what happens with ear canal malformations. A canal atresia with a normal pinna happens in close to 8% of all ears that are have canal atresia. Average hearing loss is a conductive 42.9 decibels. Then you have your microtias, and these are split up in type 1, type 2, type 3, and type 4. A type 1, that's where there's an interruption later on in the embryologic development. A type 4 is where that interruption happened earlier. So the earlier the interruption, the more severe the microtia. Happens only on one side 4 times as often as it happens on both sides. So a type 1 microtia, the pinna is a recognizable pinna, but it's obviously just small relative to the size that it should be. Of all microtias, this is 18.8%. The average hearing loss is 36.2. It is a less severe hearing loss. A type 2 is where you have primitive helix or cartilage. That's 19.8% of all microtias. Average hearing loss is a bit more. Type 3, this is the most common. That's where you have remnants of the soft tissue only. You don't have the cartilage under. It's just kind of thinking about the earlobe and the tissue that's on the outside. You basically have a maximum conductive hearing loss. You can have absence of any external ear parts. It's rare. I've seen it where it was a bilateral anotia, and it was a completely conductive hearing loss. It's greater than what would be suggested for a max conductive. I'm sure that there's some examples in there that move that average up to 74.3 because there's such a severe degree of hearing loss. There's some mixed component to it. So bearing in mind that's an average. But it is possible, believe it or not, to have more than a 60 decibel conductive loss. It's rare. Supposedly that's greater than what you should have for a conductive loss, but happens. So, close-up example of an ear, external ear microtia and ear canal atresia. These, that's looks about like a type 3. There may be some cartilage in there, and so it's kind of type 2 to type 3. things don't always line up as a nice category, but it's that's a typical one. And again, remember that happens only on one side 4 times more often than it happening on both sides. Some other auricular dysplasias are a microtia. You can have a cleft pinna. You can have these lop ears where the pinna is literally like just over. You can have cup ears where they're like cupped outward, but you don't have a lot of arches all through. Like you don't have your crus of the helix, you don't have your cavum concha, your symba concha, you don't have the rest of this. It's literally like just a smooth cup. Low set ears, that happens actually fairly common in some of these syndromes, these low set ears. And strangely enough, you can have absent earlobes. That's just strictly cosmetic, but it's not common, but it's one of those things where you might see absent earlobe. Auricular dysplasias, I actually talked about this. This is a repeat slide, sorry. Here's something I want you to have some familiarity with. I'm not asking you to memorize it, but just to get a sense for what some of the prominent syndromes with craniofacial anomalies are. A lot of children's hospitals have craniofacial programs where you'll have multidisciplinary teams evaluating children who have craniofacial anomalies, like a cleft palate, like hemifacial microsomia, take a look. Your Treacher-Collins, kids with Crouzon syndrome, kids with Down syndrome, mentioned hemifacial microsomia. I've had probably 4 or 5 kids in my caseload over the years who had hemifacial microsomia. Apert syndrome and otofacial cervical syndrome. These are syndromes that are rare in the big population, but if you're in a children's hospital, you're going to see these several times a year. So some familiarity is a good idea. Typically, what happens with these is that you just have some abnormality of the cranium, of the bones of the face, and so that has an influence on the opening of the ear. Surgical interventions. Well, if you have a microtia or an anotia, there can be an ear reconstruction that's typically done by a plastic surgeon. Skin tags, just a surgical removal of it. Cup ears, this is where they can do an excision behind the pin and just fold it back. It's more for cosmetic purposes. Periauricular pit, typically don't need to do anything. Stenosis, either from the exostoses, or if it's a developmental, as in the canal was stenotic at birth, you can have an otologic surgeon open it up, bore it open. You can have cancer of the ear canal. When that happens, then typically there will be this wide excision, like just taking off a lot of the tissue. If it's actually a metastatic carcinoma, then that's where wide excision as well as chemo is typically given. If you have an ear canal atresia, typically you wait until the child is at least 4 to 6 years old. The timing of when that's going to be done actually is controversial. There's some other audiologic interventions that can be used, such as a BAHA, that might make the meatoplasty less necessary to do earlier on. The earlier it's done, the more problems can occur. So sometimes there's really good reason to wait. But eventually, if the ear canal is created, as in a meatoplasty, an external auditory meatus, so a meatoplasty, that's something where an otologic surgeon will literally just drill out the canal. And we're actually going to talk a little bit about that, surgical opening of the ear canal. It's a very significant surgery that's done, and almost always that person needs audiologic interventions, so I want you guys to have familiarity with the whole thing. So there's different grading systems that determine or kind of guide an otologic surgeon for whether or not to do the surgery. But here's just kind of like a more broad perspective. This is not a grading scale. This is just to consider favorable versus unfavorable conditions. So, favorable conditions being they have good sensorineural hearing. There's some cartilage of the pinna, and it's approximately a normal shape. There's some radiologic evidence of there being a middle ear cavity, like there's actually a middle ear. If you're not born with an ear canal, you don't necessarily have to have a middle ear. If there are ossicles, that's a good thing. Again, not that you don't necessarily have to have normal ossicles, or even there. Radiologic evidence of the normal bony cochlea. The cochlea itself might be abnormal. There may be some hearing down there. So just because you have normal sensorineural hearing doesn't mean that you have a normal temporal bone where the cochlea is. And then another favorable condition would be if there's a normal position of the temporomandibular joint. Unfavorable conditions would be abnormal position of the auricular cartilage, and if there was a previous attempt for surgical reconstruction. Likelihood of being able to do it successfully after that is not so fantastic. Wow, I am duplicating slides. That's weird. So, audiologic interventions. Don't have to do surgery. You can do, literally, if it's a stenotic ear canal but a normal pinna, you could do an air conduction hearing aid. You could do a Baha. If it's an atretic canal or if there's an abnormal pinna, you have a microtia. That's where Baha can come in. You could do Baha on a soft band until the child is 5 years old, or if the skull is thick enough earlier than that. The Baha is the abutment is, or the piece that's implanted is a titanium screw that the skull just needs to be thick enough that the screw can be placed by the surgeon, and then the skull, the bone, allowed to integrate. You get this osseointegration, and once that happens, then you can snap the Baha on, and supposedly the sound quality is fantastic. Given that this happens, well, whether it's both ears or it's only one ear, you're almost always going to need an FM system. So, our etiologies. Just a second, folks. If you hear the crying, that's a toddler. She was napping. We're moving ourselves through, though. We're almost done with this lecture. Okay. So, thinking about this, how much hearing loss you're going to end up having. So this is just like talking about conductive hearing loss in general. With an ear atresia, you're going to get your max conductive. If you have an eardrum perforation, the amount of hearing loss is proportional to the size of the perf. An eardrum perforation with vesicular discontinuity, where literally the malleus stapes, where something is broken in between, bordering close to a 40 dB conductive loss. Total loss of the eardrum and the vesicular chain, 50 dB loss. If you have an intact eardrum but an vesicular discontinuity, you would have more hearing loss than if you have a loss of the eardrum itself. It's almost like the eardrum is acting as a baffle. So, just for perspective. So, what happens if you have a microtia or an anotia? There is a staged repair that's done, literally four procedures that would be done in order to essentially recreate the ear. Typically what's done to start is the surgeon will literally take some x-ray paper and put it over the good ear side. Given this happens 4 times more likely that that one ear is the ear that is missing. So in this example, in this picture from the Bluestone Surgical Atlas 2002 encyclopedia, this child would have a microtia and atresia on the right side. So the surgeon is just drawing out physically just the shape on the left ear, and then they would take that and flip it over so that they could see where and how it should appear on the side where it's off. Okay, so bear in mind that we talked about the classes type 1, type 2, type 3, and type 4 microtia with an ear canal intrusion with normal pinna. The way that it is done, again, it's done in 4 stages. So here's that example of the child with the right-sided malformed ear. The surgeon harvests cartilage from the ribs. So remember that X-ray paper. So they'll literally take that X-ray paper and they will lay it over the cartilage with the of the ribs, kind of right in the middle of the chest, and draw out where they're going to harvest some of that some of the cartilage. Once they take this out, they literally attach the skin wrapped around where it would be, side view, the rib base, and then where the helix is going to be. They carve out, they exaggerate some of these pieces, the triangular fossa, the scaphoid fossa, and you can imagine underneath all of this there's going to be the remnant tissue. So here's remnant tissue underneath this little like finger of ear. They've got that X-ray template piece sitting over top with your harvested cartilage. They make a cut, and with scissors going underneath it, they make basically a half moon, and then they slide under the harvested tissue, the harvested cartilage from the ribs, and then they put drainage tube in there. They close off, and they let this whole area become vascularized. This basically transplanted cartilage. In stage 2, you've got the cartilage has a good blood supply. They're going to physically remove, they detach that remnant of the malformed ear, and they kind of rotate it downward, and that part of that is creating the earlobe itself. And they graft over with skin the area that this malformed the remnant tissue was. Here's an example. I don't think it looks very good, but this literally, you can see this is where the that remnant tissue was creating the earlobe, and then underneath, this is where the harvested cartilage has been bored out. The ear canal isn't open yet. So in stage 3, they'll make an incision and elevate that ear. So right now they're going to cut away from this and start to kind of lateralize that tissue to the side. And so that's where you end up with a pinna, something that is in fact externalized, using harvested cartilage. You can have an alternative to doing that microtia repair, literally just doing a prosthetic ear, something where you make it out of silicone and you make some posts that are osseointegrated, and you have that ear on the side. It's only cosmetic in nature. That kind of thing can happen, where perhaps you could have the ear fall off. I think it sounds like a wonderful party trick, but for people who that might happen to accidentally, it's not a whole lot of fun. I don't know anyone who's had a prosthetic ear, but have seen a few auricular repairs. So how often it happens? 1 in 10,000 or 1 in 20,000. I had indicated before that 1/4 were bilateral. This other, original bit of information must have erred on the side of, well, it's more like 1 out of 3, noting the maximum conductive hearing loss of 60 decibels. It's very common to have a fused malleus incus complex, so the malleus and incus form from its own tissue. The stapes forms from different tissue, so it's fairly uncommon for there to be a stapes fixation. It's important to consider in whether or not the ear canal can be bored out. Has to do a lot with the positioning of the facial nerve. So if its position is normal, so the 7th cranial nerve, if the position is normal, that's good. If it's completely covering the oval window or completely covering the stapes, that's very bad. That gives you reason that that surgery might not be worthwhile, because if you damage the facial nerve, then you can have some real problems. So management, I had indicated, Baha could work well. If there's a bilateral atresia, you would repair the external ear first. You'd repair the atresia later. You do it one ear at a time. You do it in the ear that has better hearing and more favorable anatomy. If you have unilateral atresia, then preferential classroom seating might be useful, might not be. Follow otologic, follow the good ear very, very closely. When to do an ear canal atresia repair, as noted, that's controversial when you're going to do it. When a child has an ear canal atresia, very often, you're going to do CT scan pretty early on while the child is still only a few months old, noted here several months, and you're going to do another one some years later. But it's important to do a CT scan pretty early on, in part because 4 to 7% of children with ear canal atresia do have a congenital cholesteatoma, which I know we haven't talked about congenital cholesteatoma yet, but that's something that we're going to hear about, and that's very important to know if there's congenital cholesteatoma. Knowing what the temporal bone anatomy is helpful in determining if the child is a candidate or not a candidate, and that's going to help with planning and strong implications for counseling. Ear canal atresia. This is an important grading system to consider, at least around our area. My understanding is that this grading system, called the Jarsdorfer grading system, is very important. So this pretty much, this comes mostly from radiologic studies, CT scan, for instance. Every one of these different parameters gets a single point, except for a stapes being present, even if it's abnormal. If a stapes is present, then that's worth 2 points. If a patient has a score of 6 or higher, means that they are a better surgical candidate. If they have a score of 5 or less, they're not a good surgical candidate. So basically it's a 6 out of 10 or above, they are a good surgical candidate. Okay? Just looking at my notes here along the side. TMJ position is not part of one of these parameters on the Jarsdorfer grading system, but it is important. And depending on what's happening with that, it actually may mean that you have a good Jarsdorfer grading system score, but still not a surgical candidate. It may be that the separation between the middle ear and the brain, which actually can be a very thin layer of bone there, if there's a problem with that, in fact, you may not be a candidate for the ear canal opening, separate from the parameters of the ear canal atresia. So here's an important thing. If the temporal bone has a problem, okay, for instance, if you have something called a Mondini dysplasia, if you have a Meckel aplasia, meaning your cochlea, instead of having 2.5 turns, is malformed, doesn't have the right number of turns. If you have a problem with how the semicircular canals are formed, if you have an enlarged vestibular aqueduct, so temporal bone malformation precludes a child being a candidate for oral atresia repair, because drilling into the skull means that that ear could go dead and just wiped out. A couple more slides. There's different approaches that can be taken. One is an anterior approach that's basically going in front of where the external ear is going to be, keeping, basically just trying to anticipate, well, where's the brain going to be, where's the mastoid air cells going to be, and just drilling straight in from there. There's a posterior approach, which may be necessary depending on how the surgeon was trained and whether or not the surgeon needs to identify certain landmarks. The approach apparently is what's called a canal wall up mastoidectomy, where they're able to identify where the horizontal semicircular canal is, the HSSC, that's a horizontal semicircular canal, and they would enter the middle ear, literally enter the middle ear up through the attic. So here's an example. This is the right ear. The patient's nose would be facing out toward us. So imagine this right ear has been repaired. This skin plug, this is where the ear canal is not, but should be. You've got a fused malleus incus, but you do have a stapes present. You've got mastoid air cells, all these little nooks and crannies there, and then you have a cochlea, kind of on the other side of the foot plate of the stapes. Where that's supposed to happen, you can basically look on this right side. This is where you have a bony atresia, temporomandibular joint. That's the top of the jaw. Where the hole for the ear canal ought to be is basically like just right in connection with that. So the way this would be done, literally the ear is pulled away and folded up and over. The canal itself ends up being very, very straight but huge. There's a reason why it's made very, very big. In fact, this sounds weird, but it's called the rule of thumb. The surgeon wants to make the ear canal hole big enough for him to or her to place their thumb inside. And the reason for that is because it is this always squeezes down. It always gets smaller. It always basically swells in. And if you make it too small, then the swelling can literally just cause it just to go just close right on over again, and you've got to do an ear canal atresia again, or atresia repair again. They take a skin graft, basically from the upper arm and like somewhere where there's not hair, so you don't have hair in this. They put a skin graft where the eardrum, basically they create an eardrum, and then they line the skin over the open bone and stitch in together. Complications sometimes, since neural hearing loss, and that could be profound. You can have stenosis. That does happen a bit of the time, but you can use a steroid to keep it from getting too swollen. You can have the eardrum literally lateralized off of where it's supposed to be. You can have a revision surgery. Now, how good do things end up being? 50 to 75% of the time, hearing levels can be 30 decibels or better. 1 year post-op, 60% of the time, speech reception threshold was 25 decibels or better. And almost half of these people, 1 year post-op, had an SRT of 10 to 15 decibels. They still have some conductive hearing loss more often than not, but if you could get your SRT down to 10 to 15, you're doing pretty good in most situations. 1 year post-op, some things weren't as good just over time. It's only 46% had an SRT of 25 decibels or better. With revision, that came up a little bit. 64% had 30 decibels or better. What that indicates is after about a year, quite likely they're still going to need hearing aids, but certainly the amount of conductive hearing loss is a lot less than what you might otherwise have, which is that max, roughly max conductive 60 decibel loss. All right, gang, 1 hour, 9 minutes into this lecture. Let's pick up again with middle ear.